Okay, good afternoon, everyone. My name is Claire Reedy, and I'm the Program Manager at the Health Federation of Philadelphia for the Mobilizing Action for Resilient Communities, or MARC initiative. I'm joined in the room by my colleagues Leslie Lieberman and Carolyn Smith-Brown, and we're delighted to have you all with us today for the MARC Brown Bag webinar series. Before we get started, I do have a couple notes to share. This session is being recorded and will be archived on the MARC website. And at the moment, all participants are muted, so please use the questions pane on your GoToWebinar control panel to share your comments or questions, which we'll address at the end. Mobilizing Action for Resilient Communities is a learning collaborative of 14 cross-sector networks that are using the science of adverse childhood experiences to build the movement for a just, healthy, and resilient world. MARC is coordinated by the Health Federation of Philadelphia with support from the Robert Wood Johnson Foundation and the California Endowment. You can read more about the communities participating in MARC on our website. We also post monthly to the Shared Learning series, in which you can read about key themes emerging across sites and get related resources. MARC has an impressive National Advisory Committee, and I'm sure many of you recognize some of the names and faces here. We're very thankful that they have graciously agreed to take on this webinar series. You can visit the MARC Brown Bag webpage to access the webinar archives and register for our final session on November 8th with Dr. Linda Chamberlain to learn more about capacitar and practice several brain-body modalities that have been shown to be highly effective in promoting resilience, healing, and well-being. Today, we have the pleasure of hearing from Dr. Brenda Jones-Harden of the University of Maryland, where she is a professor in the Department of Human Development and Quantitative Methodology. She also chairs the committee of the board of 0 to 3. For more than 35 years, Dr. Jones-Harden has focused on the developmental and mental health needs of young children at environmental risk, specifically children who have been maltreated, are in the foster care system, or have been exposed to multiple family risks such as maternal depression, parent substance use, and poverty. She is particularly interested in using this research to inform practice with respect to preventive interventions to promote positive outcomes for children reared in high-risk circumstances, such as home visitation and early Head Start. Brenda, we are very thankful for your contribution as a member of the MARC Advisory Committee and delighted that you could join us today. I've got your slides ready to go, so just let me know when you want me to advance them.
Thanks, Claire. I'm happy to be part of this webinar to talk about evidence-based parenting interventions as a way to buffer young children against adversity. Okay, Claire, let me move on. So I'm going to tell you really quickly what I'm going to talk about today. I'm going to think about adversities in the conceptual context of toxic stress and its effects. I want to talk obviously about how positive parenting can be a buffer for children who are experiencing toxic stress. And then I'm going to review some of the evidence about parenting interventions for families experiencing toxic stress with a particular focus on an intervention that we have been implementing in the context of early Head Start. Okay, Claire. So I'm going to put up, I know all of you probably on this call know a lot about ACEs, so I'm just going to do this one slide, which I love, which comes from the National Child Traumatic Stress Network, which helps us think about how children who are exposed to early adversity end up with lives that are characterized by mortality and early death. As you can see, they sort of start out with disrupted neurodevelopment, move on to having social, emotional, and cognitive impairments, which leads to the adaptation of a lot of risky behaviors, some of which are health-related, others are psychologically related. What we're trying to do in the work I'm doing with many of my colleagues is to think about how we can prevent children from going through this trajectory by providing parenting interventions that allow parents to promote their development and really prevent some of the impairments and negative behaviors that occur later on. Okay, Claire. So just quickly to go through, and I'm sure, I'm preaching to the choir here. Many of you know about Jack Shonkoff's 3 levels of stress. He talks about positive stress. He talks about tolerable stress. And his definition of toxic stress, I'm going to read verbatim. Prolonged activation of stress response systems in the absence of protective relationships. And I'd like to really talk about this verbatim because that second phrase, in the absence of protective relationships, is a phrase that sort of gives us the foundation for our work when we're thinking about trying to help parents provide those protective relationships with their children as a way to avert the results of toxic stress. Okay, Claire. So obviously there are lots of risks and contexts these that relate to toxic stress or early adversity, poverty being the great disequalizer, but all the things that go along with poverty, like sociodemographic risks, and we also know that poor families are more prone to things like parental mental illness, parental substance abuse, and compromised parenting and child development. Okay, Claire. So let's think just quickly about the consequences of toxic stress as a way to sort of give us what we want to look at and what we want to try and avert for children. We know that there are a lot of physiologic consequences of toxic stress, including increased heart rate and blood pressure. And you all probably are familiar with all the research on cortisol, the stress hormone, that suggests that children who are experiencing toxic stress show this atypical pattern of cortisol production in response to stress. So they might have this elevated pattern of daily cortisol production, sort of like, you know, always waiting for the tree to fall. I have to be in this fight flight mode all the time. Conversely, you might see this sort of blunted pattern, which some researchers suggest is the worst kind of pattern to see, where children sort of are saying, I'm turned off from the world, this world is too much, I'm just shutting myself down. So we also see lower threshold for response to stress, but importantly, and that last bullet is the one that's most important to me, that we really can think about the stress response as being mediated by the caregiving interactions that children experience. Okay, Claire. So there are lots of outcomes that go beyond the kind of cortisol things that I talked about before. Certainly on the physiologic side, we see disrupted brain architecture and functioning as a result of this altered pattern of cortisol production. We also see effects on other organ systems, and we see a host of negative child outcomes in the health domain, cognitive domain, mental health domain, and some researchers, including Jack Shonkoff, suggest that when you think about some of the physical health outcomes, that as well as the mental health outcomes, that this experience of toxic stress might be the root cause of some of the disparities you see between SES and, in fact, racial groups as a result of their early experiences. Okay, Claire. So just quickly, just to talk about some of the psychological consequences of toxic stress, and we're looking at a lot of these in the work I'm doing. You see increased arousal in young children. You see a host of developmental delays. You see executive functioning issues, which, remember, Jack Shonkoff kind of talks about these as your air traffic control system, how you concentrate, how you control your impulses, how you inhibit your behaviors, all those kinds of things that help you to perform better across developmental domains and certainly in school, language delays, cognition, academic challenges, and certainly internalizing and externalizing problems later on in childhood. Okay, Claire. So now I'm going to shift because, right, okay, we know the bad news, toxic stress is bad for children. We got that. We know that. But what is important for all of us who are interested in intervention is how can we promote more positive outcomes for this group of children? And so we go back to the literature on parenting, and I'm not going to go through all this literature, but obviously you all will have the PowerPoints to check into these. But look at what I have in red and in italics. That we know that positive parenting gets you a lot of very good outcomes, even if you happen to grow up in a high-risk family. So clearly what we're trying to do with parenting interventions is really make sure that despite poverty, despite intimate partner violence, despite all these other kind of risk factors, that if parents, and we're not blaming them, but we know that if they're able to provide children with a certain kind of parenting experience, they really can help their children move past some of the negative consequences that might occur because of these early adversity experiences. Okay, Claire. So I want to help you think about what's coming out of the National Academy of Sciences. Many of you might know that last year, a tome, one of their big volumes, came out about parenting and what it means for child development. And these are just some of the most important kind of parenting practices that came out of this volume that are important for producing positive outcomes in children. So they talk about contingent responsiveness, that serve and return that Jack Shonkoff talked about, a parent being able to observe a child and follow their lead, things like that. Warmth and sensitivity, the importance of routine and reduced household chaos. Some of the shared book reading literature and talking, providing children with language stimulation that, of course, helps with their school readiness and academic outcomes. Focusing on children's health and safety and use of appropriate discipline. So these are the practices that they've sort of delineated as being most important for producing positive outcomes in children. Okay, Claire. So the NAS volume goes on to suggest, well, what are the interventions that exist that can support these positive parenting practices? So they delineate things like formal sources of parenting support, interventions targeted to specific populations of parents, and federal efforts to support parents. And one of the things that they mention explicitly is the import of having interventions for parents who are facing adversities. And that's what I want to talk about today. Okay, Claire. So what does the NAS scholars suggest are important elements of effective interventions? I've listed quite a few of them, but I'm just going to go through the ones that are in red because these are, to me, the specific elements that are mentioned by this NAS volume that really are important to us as we think about children who've experienced early adversity. So one, tailoring interventions to meet the specific needs of families. So it's a one-size-fits-all approach does not work with these families. We have to think about what their specific risk factors are. Are moms depressed? Are there parents who are incarcerated? Are there parents who have substance abuse problems? And the interventions have to be adapted to meet those specific needs. Integrating services for families with multiple service needs. In other words, again, our one single program, our Early Head Start program, or even some of the parenting interventions I talked about are not going to be enough. They have to be, as Deb Darrow said, centered in a context of multiple services that address family needs on multiple levels. And then, of course, addressing trauma, which becomes a huge issue for a lot of our families who are experiencing adversity. Okay, Claire. So I like to think about this in a public health framework, right? So we think about primary prevention, these community-based public health programs or universal education programs or income support approaches that allow parents to experience less stress in their family environments. On the secondary prevention front, we're thinking about programs that are specifically designed to reduce environmental risk for toxic stress, like early care and education, parent education, family support, and income support. And on the tertiary prevention side, which really is what I'm going to focus primarily on today, we're really talking about interventions for children who've been exposed to some level of toxic stress. So these more explicit child-oriented, parent-oriented, dyadic, or family or even classroom interventions. And obviously, I'm going to be focusing on parenting interventions today. Okay, Claire. So I'm going to list some, okay? I'm going to list several, and I'm going to ask you to put a tag in ABC, which is the third bullet down, because I'm going to be talking about that more explicitly in the latter part of the presentation, because that is the intervention that we delivered. So Triple P is one that I want to bring your attention to. What I really like about Triple P is that it's a multi-level intervention, so it kind of crosses all of those pathways of prevention that I spoke about before, and their goal is to improve parenting skills and reduce behavior problems. Really nice data at a community level on how Triple P can improve parenting, even for very, very high-risk parents, because they get a more explicit intervention. And mind you, this list that I have is not exhaustive. These are the ones that have clear evidence that they work. PCIT, the next bullet, parent-child interaction therapy, you all might know that it's probably one of the very, very few interventions that has been found to reduce child abuse. It came out of the parent management intervention field, and there's a lot of coaching that occurs in this intervention, as many of you might know, that is focused on improving the parent-child relationship and improving parents' capacity to manage their children's behavior. ABC is the next one up, which I said, just put a tag in that, and I'm going to go back to that in a minute. Okay, Claire. Another one is CPP, a more therapeutic-oriented program, which is why you sort of see the psychotherapy word in there. Sometimes it's called parent-child psychotherapy, but it comes out of an infant mental health framework, very focused on the dyad, much more focused on reflection and observation than many of the others. As a result, it's not as brief as some of these others. Most of the research now suggests that about a year of parent-child psychotherapy is what you need. Their focus clearly is on enhancing the parent-child relationship, very attachment-based. Child First, the next one that I've listed, comes right out of CPP. In fact, they use a version of CPP in their work. However, because they've been working primarily with families in the child welfare system, so arguably the most vulnerable families that we have, they have added another component where they connect case management to this more child-parent psychotherapy approach. And then the other one on this sheet that I'll just mention is Promoting First Relationships, which is another program that comes out of an infant mental health approach. And one of the things that they use is video coaching, where parents go back and look at themselves and reflect on what they see in terms of their own parenting. Okay, Claire. Okay, the last few I'm going to talk about, and again, this is not an exhaustive list, but these programs have really a lot of very good evidence in terms of their ability to improve parenting. Family Checkup, another short-term intervention which is designed to promote positive parenting, another one that comes out of behavior management, and another one that has some levels. So you see a family in a WIC clinic, for example, they get 3 visits, one of those visits is around assessment, and they make a decision at that point about whether parents need a more intensive intervention, and usually they go into some kind of positive behavior management intervention. Safe Care is another one that's been used primarily with children in child welfare. Again, arguably the children who are most likely to experience toxic stress. They work a lot on parent-child interaction, but they also have some elements that really are not focused upon in other interventions, like focusing on safety and an explicit goal of reducing maltreatment. And then the final one I just want to mention is the Incredible Years, which again comes out of this parent management idea. You see some of these interventions come out of parent management, some come out of this infant early childhood mental health background, but all of these are designed very interestingly to improve the relation, the interaction that goes on between children and parents. This often has been done in a group-based format, so it's particularly good for families coming in for Head Start programs, etc. Okay, Claire. So now I want to talk to you all more carefully about the intervention which we've been implementing. And again, the reason I wanted to go through the list that I did, not exhaustive, but certainly some of the better parenting programs, is to suggest that there are many ways to do this. We chose this particular intervention because of its benefits and because of its consistency with what we were doing in early Head Start. So I'll tell you about it later, but let me just tell you quickly about our design, that we did a randomized trial where we were supplementing early Head Start home-based services with ABC, and we compared those families who were randomly assigned to early Head Start and ABC to a group of families who got early Head Start and what we call Book of the Week, a very light intervention. Basically, families got a book in the mail from us for around the same time as this program. So anyway, we did an implementation study to look at the feasibility, which I'll tell you a little bit about. And we also tried to do some work around physiologically validating toxic stress with children, which obviously this particular webinar won't be able to get to. Okay, Claire. So let me tell you about ABC. It was developed by Mary Dozier, a psychologist at University of Delaware. She's an attachment scholar and clinician. So clearly her intervention is very much grounded in attachment theory and research. It was a manualized intervention in which she was able to provide what she called her parenting coaches, lots of content to share with mothers. She has done 2 randomized trials with kids in the child welfare system, which I'll tell you about in just a second. And it is a very brief intervention, very brief, 10 sessions, focusing on mother-infant diets for the most part. I don't believe she's done any kind of trial with fathers at all, so mostly mother-infant diets in the home. But look at what I have in italics in red, that Mary Dozier suggests that what really made her intervention work is the use of videotape and what she calls in-the-moment commenting, this kind of coaching strategy where coaches provide a high quantity and high quality of comments to mothers that allow them to reflect on, think about their behaviors with their children in the moment. So experiential, in-the-moment support to parents that really look like coaching. And I might say, if you think about all the interventions that I mentioned to you, all of them have some component of this kind of reflection, either through observation live or observation in videotape, and really this idea of coaching where somebody is supporting parents to do the best they can in terms of their interaction with children. You see that being a common element across many of the programs as well. Okay, Claire, next slide. So, what is the content of ABC? You focus on parental nurturance, that sort of promoting warmth and sensitivity in children. You try to get parents to follow children's lead with delight, get them to really look at what their children are doing and be the leader of the play. And you're also trying to reduce threatening and or frightening caregiving behavior. Those are her 3 target behaviors, and she really, in the training of ABC, insists that folks who are being parenting coaches focus on those 3 target behaviors. There is some content related to overriding one's own history and our non-nurturing instincts that's incorporated in the manual, but those behaviors are not specifically targeted upon, although you get to reflect on those. Okay, Claire. Okay, so in terms of benefits of ABC, Mary has talked about really the import of focusing on kids in the child welfare system, because again, arguably those children are the ones who are struggling the most. So her 2 randomized trials have been on children in foster care, where she has found that they're more likely to be securely attached to their foster parents, and interestingly, she's found more normal diurnal patterns of cortisol production. She also, subsequent to that study, decided to look at children who were with their birth parents. And these were children who were sort of in this kind of alternative response child welfare program, where they were not deemed to have enough maltreatment to remove the children, but certainly they were families at very, very high risk who were remaining with their birth, having the birth family remain intact. And when she did a randomized controlled trial with those families, she discovered that mothers who had experienced ABC were more sensitive to their infants, and that their infants were less likely to have disorganized attachment and more likely to be securely attached to their mom. And just to put a little tag on that, that is a very, very important finding, because it's very hard to change the attachment status of children. And you all who know attachment literature might know that the disorganized group is really the group that has the worst outcomes. So the fact that ABC was able to move children from disorganized attachment to a more secure attachment kind of category was critical. Okay, Claire. So I'm going to talk about what we did. Remember, I said to you we wanted to look at implementation to see how feasible this really was, because what we're talking about is adding another parenting session to families' experience of home-based early Head Start already. So they were getting double the intervention. It took us about 13 weeks to get through this 10-week intervention with these families. So we did find throughout our implementation study, as well as throughout the randomized controlled trial, that adding ABC to home-based early Head Start was feasible. So going back to our prevention framework, you can see that what's happening is these families are getting this more sort of primary, secondary prevention of early Head Start, and then they're getting this additional tertiary intervention. And so in a way, the higher risk families that might need these kind of interventions can receive it even within that prevention framework. We also were happy to see that this kind of parenting intervention is very consistent with early Head Start standards that are focusing on improving parent-child interaction. But interestingly, one of the things that, and you'll see this in my second bullet, EHS does not equal ABC, this ended up being a good thing and a challenge at the same time. Home visitors were able to distinguish that we were giving families something very different than what they were giving, so that made them more invested in our efforts. But it became sort of challenging for families to try and understand, now, which home visit am I in and how should I respond to my infant? Should I be focusing on teaching my infant child development, or should I be, responding to the coach who's saying, follow my kid's lead? So those kinds of things were challenges, but certainly things that we were able to work through. Clearly an issue for us as we were delivering this became, this issue of sustainability. We were always thinking about how can we make sure we're not just parachuting a program in and leaving. And one of the big challenges that occurred for us was whether home visitors in early Head Start had the resources to do this kind of service delivery, particularly in terms of videotaping, because as I mentioned to you, this videotape review is an important part of a lot of these effective interventions. So the question becomes, how do we help this workforce really get the technological skills to videotape a parent and then go back and use the videotape with parents to reflect on their parenting behaviors? Now, many of our home visitors were worried that families would not want to be videotaped. We found this to be not a real problem. Certainly some people said, I don't want to do this videotape, but it was a very, very small proportion of the people who said that. So it was really more an issue of comfort on the side of the practitioners. And then obviously thinking about training staff to do this kind of intervention. Mary Dozier, as do many of the folks who are using these kind of approaches, really are concerned about having their families, having their practitioners be able to do this kind of work with fidelity. So sometimes it's very hard for families to be able, home visitors to be able to do that. Okay, next slide, Claire. So I just want to talk to you all a little bit about some of the findings that we had. Certainly we had to adapt the intervention for Latino families. One of the things that we discovered was that, we had to really adapt all the material. So we translated everything, and any of you who are working with families who don't speak English, you might find that you have to do this with your materials, but we were able to get somebody who was bilingual and bicultural to do all of that for us. We also importantly hired bilingual and bicultural staff to deliver ABC. So it wasn't enough to have a person speak Spanish. We wanted somebody who really was from this culture, who could engage families in a different way, and that ended up being pivotal to us, as most of our families ended up being Latino. We had to think about family context as we adapted this. As I mentioned, most of our families were Latino, so they had multi-generational households. Sometimes we were delivering the intervention in a bedroom because that was the family's whole house. So we had to find a little spot in the corner of this room, or we had to do it on the bed. Sometimes we couldn't do it at certain times of day because there'd be a family sleeping in the next room who worked at night. So we had to think about these. We had to think about the role of the father. This was a particularly partnered group, as my colleague often said, who, had lots of partners, spouses, fathers who were helping to raise the children. we had to think about incorporating them, and we certainly did incorporate fathers in a lot of these visits. And obviously, one of the things that any home visitor has to think about in terms of engagement is the work schedule of parents. We have parents working all night. We have parents working all day. We have parents working in service sectors. So we were like squeezing in these visits in between times when parents could be home, which was a challenge for us, but we were able to do in about 90% of the cases. I do want to mention one cultural issue. The following the lead piece of Mary's became a particularly challenging target behavior for parents. They often said this is not consistent with how we were raised. We were taught, you know, that children should listen. We can't be following children's leads. So really trying to help parents understand what that meant. And that didn't mean that you didn't provide boundaries for your children and all that kind of parameters and things like that. But this is really in terms of being with your children in a different way. One other quick thing I'll say is not only did we translate materials, we thought about this cultural thing. So there's a montage, a beautiful thing that occurs at the end of ABC where you take a family's best moments that you videotape and create like a whole movie for them that have their best moments. Our parents loved it. They asked for second and third copies so they could send to their families in Central America. I mean, they just loved it. So we did things like adapting the song we used. We used Spanish songs for this montage. Okay, Claire. And I just want to tell you really quickly what our results were. We were able to replicate some of the results that Mary did. We didn't do an attachment measure in the way that she did, but we looked at parent-child interaction in a videotape, and what we got was positive outcomes for parental sensitivity, for positive regard, for intrusiveness, and a sensitivity composite we did. Basically, what that means that parents who experience ABC ended up showing better parenting. And interestingly enough, where we got our medium effect, which is hard to get in intervention research, as some of you might know, was on the intrusiveness side. And intrusiveness, you know, that's parenting behavior where parents are sort of in the kid's face, controlling everything. And if you remember what I said about following the child's lead, that suggests that that area that parents suggested was a challenge was the area in which we had the biggest impact. So I think that's important to think about. You know, certainly we know from some of the prevention literature that if a family is doing okay in certain kinds of things, that's not going to be where you see the impact. The impact is going to be where they struggle. Okay, Claire. So I'm just going to try to pull this together so I can open it up to questions. First of all, I hope I've convinced you, and many of you knew this already, anyway, that toxic stress is detrimental, not just to these, you know, sequelae that we've been talking about from the ACEs in later adulthood, but sort of going back to that pyramid that the National Child Traumatic Stress Network puts out, it's detrimental to early development, which leads to these negative physical, developmental, and mental health sequelae. But here's the good news, that if you think about what we know about parenting, right, and enhancing the parent-child relationship, which is the goal of many parenting interventions, you can promote positive parenting in high-risk families and thus can reduce the effects of this early adversity on children, right? So we have an evidence base that suggests that if we incorporate some of these kind of parenting interventions in our prevention approaches, like we did in terms of early Head Start, but also inside of child welfare systems and other child-serving delivery systems that affect children who've experienced toxic stress, that we can do something about promoting more positive outcomes in these children's lives. So in my last slide, I just want to thank everybody who has helped me get this work done. So I'm thankful to our funder. It was part of a consortium to buffer children against toxic stress that was funded by the Administration for Children and Families. Thanking my co-director, Lisa Berlin, and our whole parenting team. We called ourselves Partner for Parenting Team, as well as the many early Head Start staff and families that had to work with us, and certainly Mary Dozier and her colleagues, Caroline Robin, and other folks at the University of Delaware. So at this point, Claire, said she would be getting questions, fielding questions, and she'll be able to answer me some particular questions.
Thank you so much. Yes, and the questions are coming in. So just as a quick reminder, the slides and a recording of this session will be available later today or tomorrow on the MARC website at marc.healthfederation.org/brownbag. And Brenda, the first question for you is, how were you able to recruit bilingual and bicultural staff to implement ABC? That is, what approaches were most successful? We have a large Latino population in our area, so that would be something we would need to do.
Okay, the first thing we thought about was growing folks whom we knew. So I had been very involved in working with early Head Start programs for many, many, many years. And there was one of our parenting coaches who was an early Head Start home visitor who clearly wanted to expand her horizon. So I got permission from the early Head Start person because they knew this young woman was going to leave, to really put her in a different position where she'd learn a different set of skills. So I do believe that sort of growing folks whom you have in your circle who are volunteers or who may have a role as a translator or something like that is important. Or, you know, what we do, I'm actually at a university, we scour the Spanish language classes, I'll just be honest with you, and we start recruiting these young people while they're like sophomores and juniors in college. Sometimes they don't finish college, but we've got them anyway as a way to kind of build a workforce with bilingual people. The other thing that I will mention is, and Mary Dozier talked about this, you do not have to recruit people who have a certain educational background. She does believe that's important to have people with BA degrees, again, going back to my point about scouring the Spanish language classes, which we do. I mean, a lot of the folks that we recruit are just taking Spanish because they're Spanish, they're from Spanish backgrounds and they want to take the courses. They're not necessarily trying to do this kind of work, but we get them anyway. But she doesn't say they have to be clinical people. They don't have to have MSWs. They don't have to have psychology degrees. She argues that they have to have a certain approach to thinking about caregiving, a certain way of wanting children to have a certain kind of experience. Like she believes strongly that anybody who thinks you should let a baby cry is not the kind of person you would use. So one of our folks didn't even have a clinical background. She was a speech and language person who had had speech and language training in Mexico. She was an immigrant herself, and as you know, many immigrant folks can't get their degrees accepted here, but that didn't matter to us. We thought that, you know, she could do it. So really trying to be in the places where bilingual, bicultural people are, and making a decision that you're going to train them to be what you want them to be, that you're not necessarily going to get them in having that set of skills.
Thanks, Brenda. Okay, I'm going to combine two questions here. They both are about sort of the long-term effects. So the one I'll read is, has ABC or any of the other parenting interventions you mentioned been linked to reduction in child abuse over the long term?
Yes, so let me talk about ABC. Now, first of all, I will admit right up front that ours was looking at pre and post. So we don't have long-term effects. So I'm talking about Mary Dozier's long-term effects. Her effects are not in the reduction of maltreatment per se, though. I want to make that clear. Her results are in the improvement of parenting behaviors. And I would argue that if parents' behaviors are improving, if they're becoming more sensitive, if they're following their kids' lead, if they're not doing frightening things, that you're going to see lower rates of child maltreatment. But I have not seen her results specifically to lower rates of child maltreatment. But she has found that this very brief intervention has long-term effects, and she's published data on the children during the preschool period. Now, mind you, these are brief interventions that occur in the infant-toddler period, right? She's found interventions, effects that sustain themselves through preschool. And I do know that they're collecting data now for children who are like 7, 8 or so to see whether the effects are retained during that period. I also can point out that PCIT, for example, parent-child interaction therapy, has found that you can have effects longer after, the post-test with PCIT. So that's another one that's been done. And mind you, PCIT is one that has a long history, not just with victims of child abuse, but with kids with behavior problems. And I certainly would suggest that you look at that literature. Very strong literature about long-term impact. Child-parent psychotherapy, which is really geared to children who've experienced trauma, has some data on long-term effects. But again, remember their intervention is a year long and it's not this kind of brief intervention. So I would argue that, you kind of have to think about this like the multi-level approach that Triple P talks about, or even Family Checkup talks about. That, for some parents with certain risk factors, you're going to need a more intensive intervention and maybe even a longer intervention like something like CPP.
Great, thank you. The next 2 questions both address specific populations. So the first one is asking about programs specifically geared towards grandparents who are raising grandchildren. And the second one is looking for specific resources or programs for positive parenting of children between the ages of 12 and 14.
Okay, so I'm just going to admit that I'm a young child person and I don't know a lot about what is available for adolescents. I will say that a lot of the programs, the trauma-focused programs, seem to work more for adolescents, and those are programs that, like the cognitive behavioral training, for example, cognitive behavioral therapies that allow adolescent children to work through their own response to trauma. That seems to make a difference for those kids. But also some of these parent-infant interaction programs, remember I said, are taken from a positive behavior management approach. So if you go to some place like University of Oregon Social Learning Center, where they've started this positive behavior management programs with a focus on older children, you'll see them doing things like having special time with the older children. Following the lead for us is parents following a child's lead in play, but following the lead for an older child might be if a kid just really likes going fishing or really likes video games, that the parent sits with the child doing that kind of stuff. They call it special time or being with kids or, time in, those kinds of things. So if you look at those groups, you will see some interventions that are more appropriate for older children, but certainly this is way out of my bailiwick, I'll just be honest. The second question was about grandparents. I will say that Mary Dozier's perspective, I'm just speaking about ABC at this point, is that you can use it with any parent. In fact, you remember that her first foray into this was with foster parents. And as many of you know, a lot of foster parents these days and times are coming out of the kinship realm where they are the grandparents or aunts and uncles of these young children. So from Mary Dozier's perspective, ABC can certainly be implemented with those. However, I really have to say that there is very, very little evidence about particular programs that have an impact on this particular group, although most of these programs suggest that you can use them. But a study that's looked at, okay, I'm just taking a grandparent population and see what works, is not there, although they say it can be used with anybody.
All right, well, Dr. Jones-Harden, this has been wonderful, and we are just about at the end of our time together. Do you have any closing words?
My last word I'll say to everybody is, you know, I'm trained as a clinician. That was my early training, long-term approach to trauma and those kinds of things. My mind has been changed. I still believe in long-term intervention for certain children and families, certainly, but I think from the parenting side, we've got a group of programs that we all should know about and have in our repertoire, bringing into child-serving delivery systems across the board. We should use those programs really in a, you know, a way of fidelity. Now, we can't just be loosey-goosey about it. We have to be faithful to how the intervention is supposed to be delivered, but we're getting this mounting evidence that parenting can change. And we know from just a host of studies that positive parenting gets you better outcomes for high-risk kids. So I would just encourage all of you to increase your knowledge about these programs and really try them in your various service delivery systems to see if you can't adapt them to be useful for your families and children.